This evening, I think, is a great topic. I'm very excited to share with you the fact that having Dicky's knowledge on hand to talk about gastric ulcers is a really tremendous thing. He is an internationally recognized expert in this area, both in terms of research and in terms of huge clinical experience. So we are going to tap into all that knowledge and learn some brilliant stuff this evening, I'm sure. First of all, we are going to kick off talking about the actual practicality of gastroscopy. What's your routine protocol? What do we do about starving? Should people be faffing around with gags or bits of stomach tube or anything? So, Dicky, go.
Before I start, I'm going to say hi to Rachel, who smiled a lot Atherton when you said all that, Sarah, as we were residents together.
Oh, I thought she was laughing, and I thought it was.
Hey, Rachel.
Hey, Dicky.
Let me just fire some goodies up and see if it is working. Hold on a second. Play in window. Sarah and I have both been a little bit slightly late tonight, so excuse me while we get this all set up.
Poor Lou Purvis was rather stressed by our very tardy arrival, but we're here.
Play in window. There we go. Right. Let me just quickly fire that up. Can you guys see that? Fab. Avoiding gastroscopy failures, I think, is really important as more and more people do gastroscopy. I'm not going to tell you that what I do is the only way to do it. Everybody has their own little sort of foibles with it. But I'm going to tell you what my kind of foibles are. I only starve horses for about 8 to 12 hours. I don't take their water away. Horses produce a huge amount of enterohepatic secretions and a huge amount of saliva. So actually, you'll always have a residual volume of fluid within the stomach, even if you take their water away. I'm always happy that owners have remembered to starve them rather than taking the water away. One thing that I would encourage people to do is this. When I was PhDing back in the day, one of the observations that the human people had was, why don't you use local anaesthetic? And I couldn't really give a very good example, sort of explanation for that. So we do put local anaesthetic up the nose. And so we just use these little modified trach wash tubes. So if you've got one that you've been using for ages and it's about to give up the ghost, chop it off to about 20 or 30 centimeters long. The best thing that we found to block the end of it is actually blue tack. Which I know sounds a little bit Heath Robinson, then we make loads of holes along it. And what you can do is you can squirt local anaesthetic into the ventral meatus, and it can make a massive difference to the horse's tolerance of the passage of the endoscope. They'll still feel a little bit as it goes in the nostril, but for the majority of it going up the nose, they really don't care about it. Here we don't use gags and we don't pass via stomach tubes, we just pass the scope. And I think one of the things that's important to appreciate is that scopes aren't stomach tubes. You can see this is Jess, she's one of our specialist medicine nurses. She actually does gastroscopies herself. And she's just kind of demonstrating the difference between the rigidity of a stomach tube and how flexible a bending section is. So if you treat a gastroscope like a stomach tube, it's going to bend like what Jess is showing you. And as it makes that bend, that's going to whip under the back portion of your soft palate, end up in the mouth. And that's often why you'll get lots of and all that sort of nasty horse noises, and why sometimes you end up with a little bit of chomping going on if that happens as well. One thing I would say, another reason why Jess is in this picture, is if you're sort of embarking on doing lots of scopes, having the same person passing the scope for you really does make life spectacularly easy. You will get a bit of a relationship with them. You'll understand, how the scope is moving. You'll be able to be pretty quick with telling them how far you want the scope to move as well. This is one of our little favourite things. So when you are advancing the scope, so as well as what Jess is showing you, I'd encourage you guys to actually get the horse to swallow it. And so what we've done here is just advanced the scope, positioned it so it's still sort of the apex of the arytenoids, squirt a little bit of water in, the horse swallows, and off we go. And so actually getting the horse to swallow the scope is really easy with that kind of approach. And what you'll find is the person who is passing the scope will very quickly get an appreciation of that tiny little flick, that little movement with the endoscope that just signifies that the horse is swallowing. The worst people to pass endoscopes are other vets. I loathe other vets passing scopes because they always know where they want it to go and they treat it like a stomach tube and the scope is going in and out and all of that sort of stuff. So when you start doing this, don't use another vet. You know, cholera nurse, someone like that, and think about trying to understand how the horse is actually swallowing it, because it makes it much easier. I don't like gags because I've had too many horses wave their heads around pre-local anaesthetic days, and I think a gag in a mouth when somebody's nearby passing a scope, certainly for me, isn't a very clever thing. Next thing is actually to pay attention to the little markers on the scope. So it should take you around about 2 meters to get to a stomach. When you pop in, the first little place you're going to pop in is over here, so just through your esophageal inlet, and you're going to be looking straight over at your greater curvature. Takes you about 10 centimeters of advancing the scope before you hit the greater curvature, and anywhere up to another 20 centimeters to trundle round, such that you're then looking at the lesser curvature. Now, when you distend the stomach, that's the other thing that's really important. There's only one scope that's available in the UK that has a pump that's strong enough to distend a horse's stomach in anything under about an hour, and that's a stalked scope. So if you've got a stalked scope, you can just use the insufflation pump, the little air wash pump on your blue button to distend your stomach. If you have any other type of scope, you just can't. So you need an external insufflation source. There are loads of different ways to do it. Tim Brazil back in the day used to love pumping up a killer spray full of air, connecting that to the biopsy channel, opening that, and that would distend the stomach really quickly. I tend to use one of these little aquarium pumps, and that enables you, we actually connect it through the red channel on the little Christmas tree close to the light source end that sits in your processor, which means that when you push the red button in, you can then insufflate the stomach. These things will churn out around about 20 liters of air a minute, so you can distend the stomach really quickly. When you've distended it, what you'll find is over here on the sort of greater curvature above your marga plicatus, you create a shelf. So going around the outside of the stomach at the marga plicatus is a fibrous band, which means the stomach actually distends like this. So you create a shelf that the scope can sit on quite nicely. So if you position it on that, what you have is a scope which is positioned horizontally within the stomach, looking back at the lesser curvature underneath where you've kind of come in here. If you then encourage, like on this diagram here, the scope to look down to the fundus, almost fall off that edge, what now happens is the scope orientation in the stomach changes. So when you first went in, it's horizontal. When you make it look down like that, the scope flips and is now vertical. Is what you want it to do. So you want it now to come in, go all the way around the top of the stomach, down the bottom of the stomach, and then head out towards the antrum. Always remember that your antrum and your pylorus are in front and above your fundus. Your fluid is down in the fundus. So the easiest way to find out where to go is to insufflate through your scope. You'll get a column of bubbles that goes forwards and up. And that's the direction the scope kind of wants to go. And so a little bit of appreciation of how to get round, and then the distances. So the bit where people go wrong is from the looking at the lesser curvature to getting to the antrum. Within the stomach, 20 or 30 centimeters is all scope you need to get there. So for me, 2 meters to the entrance to the stomach, 2 meters 10, 2 meters 30, 2 meters 50 usually gets me to the antrum. So I would rarely go to 3 meters, scoping even a sort of big horse's stomach, maybe just over 3 meters sometimes. If you've got to 3 meters and you're still looking underwater, what you've done is you've made a loop in the horse's stomach. You're just going round and round. What I'd encourage you to do is just to come back to do, so you can see white tissue, make sure you're adequately distended, drop under the drink, insufflate, form your bubbles, go forwards and upwards, and then just sort of gradually advance. The second thing you can do if you're getting stuck in the bottom of the stomach is appreciate the bending section can act like a finger. And so if you put a little bit of rotation on it and then rock the scope gently side to side, or you just twiddle the knobs from side to side, what you can do is a bit like caterpillar action. You can make the end of the scope just keep moving. So what it'll do is it'll climb over rugal folds and kind of find a way between the nooks and the crannies of the scope. There we go. That answers that, Sarah.
Great, thank you. My next question is, which horses should we be scoping? Obviously, gastroscopy is increasingly. Oh, Dicky can hear me, but no one else can. I was going to say, which horses should we scope? I mean, gastroscopy is incredibly affordable these days. It's incredibly available. Sometimes it feels like every horse has been gastroscoped. Are we doing the right thing? Should we scope all of these horses? What are your criteria for case selection? Are we using it too much, or is it just a good thing that we're scoping them all?
Yeah, I think that's a really good. Oh yeah, Sarah and I are really on it with the technology today. We'll start again. So I think that's a really interesting question. And certainly for me, a lot of these days, I would do quite a lot of yard scoping. So we've got some relatively big sort of trainers and sport horses where they just want everything scoped. And I think yard scoping for me is a really interesting thing, because what you'll find is that particular yards have particular patterns of ulceration. Some yards that you expect are going to be full of ulcers have none whatsoever. And others that do have them will have patterns. And I think when you start to identify patterns, particularly in the location of the ulcers, so have you got squamous versus glandular? Within squamous ulceration, you have a greater curvature problem, which we think is probably more of a splash issue. So if you look at how ulcers form, experimentally, if you exercise horses, you'll get splash lesions, which predominantly occur on the greater curvature. Whereas if you starve horses, you will get lesser curvature ulcers that just reflect the sort of location of, let me just bring a slide of that up while I'm thinking about that, and I will show you. Here you go. Yep. There we go. So when we look at just within sort of yards, but you can also apply this to individuals as well. If you find a huge amount of greater curvature ulcers here, then what you're looking at is a splash effect. So you're looking at movement of acid from the fundus up to the greater curvature during exercise, in which case what you can then think about doing is implementing changes in the consistency of the gastric contents during exercise, so pre-exercise feeding. If you're going to starve horses or you're going to give them high carbohydrate diets, invariably what you end up with is lesser curvature ulcerations here, because it's just geographically closer to your gastric juice. And so I think, certainly for me, when you are doing yards like this, you can say, right, over here we need to improve what happens during exercise, over here we need to improve what happens during feeding. And coming back to kind of what to do with individuals, I think with individuals, if you are looking at race horses, then what I would do is I would look for appetite change. So one of the best people to talk to are your headlads, the people who are responsible for putting the horse's feed out in the morning. If they're not consistently eating their morning feed, or they're starting to lose condition, then I think that's pretty reasonable thing to look for. And if you look at the proportion of horses with appetite change that have ulceration, it's around about double. When we look at sort of sport and leisure horses, the number that have any sort of change in appetite is significantly less. Which means what we're often left with is behavioural changes. And I think behavioural changes are an interesting thing to talk about. I'm just going to grab a few more slides to show you guys. So there's been some work done recently looking at things like grimace scores. And grimace scores really aren't related to the presence or absence of gastric ulceration. And I think that's pretty relevant. So I think most of the time what we're looking at with ulcers is a noxious stimuli rather than a painful problem. So I think a lot of these cases we're not actually looking at something that's outright painful, and that's supported by the number of horses that we see with colic with ulceration. I think most of the time what we're looking at is more of a change in their tolerance of exercise, often their behavioural tolerance of exercise. And I think that's harder. I think everybody kind of, and I'm rambling a bit, I think everybody kind of has their own point that they are happy to look for. I think for me, I don't have any issue with scoping horses if owners just want it done. The thing that I have more of an issue with is understanding how they should respond clinically with treatment. So actually, I don't have much of a problem with anything being scoped if people want to.
And you've scoped a lot of horses. These horses where people say, oh, it doesn't like having its sides brushed anymore, or it resents girthing and that stuff. Do you think those clinical signs really are associated with gastric ulceration? And do you see resolution when the horse is treated?
I think if you look at girthiness, so if you look at girthiness purely as a presenting sign, then you will find a proportion of horses that have ulceration do have girthiness, so a change in their perception of skin contact. If you look at a lot of horses who just have girthiness, and then you look at the ultimate diagnosis, it can be associated with loads of things: skin disease, it can even be associated with stenitis, with muscle disease, with back disease. So for me, it's not a, I think it's one of those symptoms which I think has fallen a bit by the wayside. I don't think it's quite as commonly thought of as it was. If you want to use this, so I'll send a drone on at you guys now. Hold on. I'll get you some slides that explain why girthiness may occur, because it's kind of cool. And you're here, so you must be gastro nerds. So we'll do that quickly. Here we go. Share my screen again. Here we are. So we look at horses that will have a change in the perception of skin contact. There are two theories as to why that might happen. And one is what's called common pool theory, and the other is what's called the visceral reflex. And I think it kind of explains what might be happening. And first one is common pool theory. So this is where you've got general visceral afferents that come from the lining of the stomach, and essentially they plumb into your grey matter, dorsal sort of grey matter here, very close to your general somatic afferents that relay skin sensation, and they ascend in the same conscious tracts to the brain. And what happens, I think it happens, is that when you have this increased input from your general visceral afferents, because the presence of ulceration, the brain misinterprets it as a skin sensation, because it's really used to hearing from the skin, but it hardly ever hears from the stomach. So all of the neuronal plasticity that relates to the interpretation of that input relates to the skin. Now, if you look at the area in dogs where the stomach relates to, it's around about T6 to T9, which is roughly the area that we see in horses. So I think there is a neuroanatomic potential for girthiness, but I think in a lot of cases it's just really a horse showing signs of resentment. I think and that's what the kind of girthiness bit shows. The second one, which I did have on here, which has disappeared off my slide, would be I don't like sharing the screen on this area because I have to keep jumping around and it doesn't make any sense to me. Here we go. The second one, which I think is quite interesting, is actually the effect that gastric ulceration might have on the blood supply to the cutaneous muscles. So this is what's called the visceral reflex, and this is a bit of a busy slide for this time in the evening. But essentially, there are little interneurons within. Oh, sorry. Here we go, back on the slide. So bit of a busy slide for this time of the evening, but there are these sort of interneurons within this reflex arc, which actually affect the blood supply to the cutaneous polymuscles of the skin. And what we think might happen is that you get this vasospastic reflex when you've got inflammation within the stomach lining. That means the blood supply to the cutaneous polymuscles is going to be reduced. And it affects, certainly in dogs, we don't know about it in horses, really quite a wide area. And I think this, for me, is slightly more interesting and slightly more points towards what we see with ulceration in horses, is you will end up with a resentment of leg aids. Because of the persistence of leg aids, what you end up with is stimulation of those muscles then fatigue, and the horse appreciates that fatigue as discomfort. And so I tend to pay attention more to what happens when the horse is being ridden, rather than what happens before the horse is being ridden, if that makes sense.
Super, thank you. This is very interesting. I think we might move on. I guess we've talked about how to scope, which horses to scope. Hopefully everyone is fairly comfortable once they get in there, they have a good look around. One thing you definitely taught me when I first came here was to record carefully everything you see. Take pictures of all of the areas of the stomach, not just the one interesting thing that you find, because when you come back later, you might want to have another look at them. Then you choose some treatment, your horse goes away for a while, it comes back. I guess one of the biggest topics I think interests everyone is, what do you do when the horse hasn't done what you think it should have done in response to your treatment? And I guess, how do you define non-healing? How long do you give it? What do you do?
Yeah, and I think that there are two aspects to that. Then we deal with the endoscopic aspect to that first of all. I think you need to understand a little bit about what healing actually is. So when you look at equine squamous gastric disease, what you're looking at is epithelial restitution. And when we talk about that, when we talk about healing, what we're essentially doing is creating an acid-free environment, then healing should occur. Oral omeprazole is absolutely fantastic about that. So the number of squamous failure cases that we see is really small. When you think about what the squamous healing is, I think you need to consider the lesion. So I quite like this slide because it gives you two examples. The one in the middle, you would consider to be much more severe. You know, you've got a huge amount of ulceration, actually erosion, on that middle picture. It looks really dramatic and really unpleasant. Whereas the picture on the left is just a bit smaller, but it's actually a lot deeper. So the way this squamous mucosa heals is it heals by marginal replication, then raises up and floats down. So I suppose it's a little bit like corneal epithelium. And if you look at these two slides on the right, you can see little islands of squamous healing that occur. So if you scope horses really soon after you've put them on acid suppressants, you'll start to find this kind of blotchy appearance. And that's certainly what we used to do years ago when we were looking at sort of treatment efficacy. Because of that, what that means is that the one in the middle, even though it's a very sort of large erosion, is actually going to heal faster than the one on the left, because the one in the middle has got an intact lamina propria, which means that tissue itself doesn't have to heal. You've just got to get the multiplication to come and settle down. So if I was treating this, I would potentially only put that on 2 to 3 weeks of oral omeprazole and expect it to be finished. Whereas the one on the left, I would put on 4 weeks of oral omeprazole because it's just going to take longer to get better. So that's the first thing to think about with the oral omeprazole. Second thing when we're thinking about this, there's lots of stuff going on out there about which dose you should be using, how you have to give it, and all of that sort of stuff. It's worth putting that into a bit of context. If you give any version of oral omeprazole on an empty stomach, then feed 30 minutes later, Al Merritt did this work donkeys years ago, and he showed that what you can do is increase the bioavailability of the omeprazole by 300%. So you can get away with using less. I think it's really important to remember that when you look at the 4 mg per kg omeprazole studies that were done with Gastrigard, they were done with no consideration of feeding whatsoever. It was just thrown at horses in really shitty parts of the US, and it works. So you do not have to give Gastrigard on an empty stomach. You do not have to feed them half an hour later if you don't want to. It will still work. If you give it on an empty stomach and you feed them half an hour later, you will increase its efficacy or bioavailability by about 300%. Now, important to realise that the reason 4 mg per kg was chosen as a dose is that there's no benefit of using 6 mg per kg over 4 mg per kg. The number that respond to that increased dose is really teeny weeny. And so actually the biggest advantage of manipulating feeding with respect to omeprazole is getting away with using lower doses. So being able to treat horses for less or being able to treat more horses for the same amount of money. When we look at the bioavailability, once again, not all products are the same. So in the UK, all we have is alkaline buffers and excipients. The bioavailability of those guys is not as good as enteric-coated products. You can get away with 1 or 2 mg per kg with an enteric-coated product to have the same effect as 2 to 4 mg per kg of a buffered product. That doesn't mean that the enteric-coated one is better omeprazole or a more effective product. It just means that the omeprazole is protected to a high degree. They both work, and they both have their own dose rate that relates to the way that they're produced.
And I guess we don't want to go on getting endlessly better bioavailability. Am I right in thinking that it's above 8 mg per kg that you might start to see some adverse effects?
Most of the adverse effects you get are actually more with prolonged administration, and even then you've got to give them quite a lot, and then it's sort of renal issues and mainly in endurance horses. So yeah. One thing I'd like to say about treatment failure, when we talk about squamous treatment failure, this slide here is not an example of that. This is just a simply gigantic lesser curvature ulcer. And in 28 days, it has significantly got better, but I think to expect that to be fixed in 4 weeks is pretty unreasonable. You can continue treatment for another month and it's better. So that's not treatment failure. That's just the speed of treatment or speed of healing in reflection to the size of the original lesion. This is treatment failure. So this is a horse day 0. You can see you've got these little sort of multifocal erosions sitting on your greater curvature, and day 28 looks exactly the same. You do need to remember that some horses will have ulcers that reform very quickly, in some cases in a shorter period of time as 24 to 36 hours. So if they have abruptly stopped treatment prior, a couple of days prior to when you rescope, then what you might be looking at actually is not treatment failure, but rapid recurrence. You need to always ask the client about that. If you know that it's been on treatment, then what you want to think about is why has this happened, and there are two explanations to that: incomplete acid suppression or squamous mucosal weakening. So you always want to think about it from both directions with these guys. So incomplete acid suppression, number one, poor tolerance of the oral drug, horse waving its head around, all of that sort of junk, horse spitting it out, it just won't eat it. And then I think absolutely the injectable formulation is spot on. We use the IM version. The IV version used to be fab. When we could get hold of it, it's ferociously expensive and it doesn't last very long. And so we tend to use the Bova IV formulation, and it works really well. And it gets rid of squamous ulceration very quickly. I mean, really very quickly. Worth bearing in mind that the tort of lesions that were present within that study were predominantly erosions. So erosions heal very quickly, ulcers heal slower. Therefore, if you have a population predominantly made up of erosions, you're always going to flatter the treatment that you're giving. And so that certainly is one approach. The other approach you can think about, if you've got someone who really does want the injectable formulation, is 12-hourly omeprazole administration. So do it BID instead of SID. When you look at the variability in duration of acid suppression, it is greater than the variability in the magnitude of acid suppression. So the problem with some horses is that they just don't acid suppress for long, which means you can get around that by replacing the drug. So give that every 12 hours. That's one possibility. Next thing you do is look at a poor omeprazole effect. So are you one of that small proportion of the population who don't do well with omeprazole? In man, it's about 4%, in which case what they use is different versions. So esomeprazole is the S isomer, as it says in the slide there, and the S isomer is about 4 times more potent than the mixture. So what you're doing is you're picking out the better bit of, racemic omeprazole and giving just that. And that certainly can work really well in horses. I use omeprazole more as a preventative, mainly because of the easy access of human omeprazole in the form of Nexium or generic esomeprazole. I think it works quite well as a preventative. I don't use much of it as a treatment. I don't think it has much of an advantage. I think the majority of what we see in horses is very similar to what happens in people. And I think the biggest problem we get in horses, actually, particularly if you're using the original product, Gastrigard, is Gastrigard only treats around about 500 kilos, whereas the generics treat 6. And so you'll always get more in a tube of generic. If you look at the omeprazole in Gastrigard is a better version of omeprazole. It has a higher S isomer sort of mixture than the non-generic, in the generic form. But realistically, the dose thing I think is more of an issue. So that's poor omeprazole effect. I would tend to go with the injectable most of the time, or BID dosing. Next thing to think about is, have you got this? So this is squamous weakening. And this is quite cool. So some of the really nice stuff that Ben Sykes has done, particularly in racehorses, showed that there are some racehorses that actually, when you acid suppress them, get worse. Years ago, Frank Andrews did some Ussing chamber work where they did little explants of the squamous mucosa, looked at impedance, and then changed the diet. And what they showed is that there are some horses who will ferment what's in their stomach. And if you acid suppress the stomach, fermentation will increase because the acid acts as a bit of a brake on that. And they produce these volatile fatty acids, and those cause a change in the way that the tissue develops and the tight junction. So essentially, it creates a weak barrier. And what Frank showed was that when you do that, you can start to get evidence of ulceration at a pH of 4 instead of a pH of 2. So what you're now doing when you've got this squamous weakening is you're allowing ulceration to form more rapidly, because a bigger proportion of your gastric contents will now irritate and cause ulceration than you had before. So endoscopically, if you see this, you might not have an issue with your degree of acid suppression. You might have a weak stomach. There is some quite cool stuff done donkeys years ago in Australia by Al Jassim, and they looked at these sort of ones, and they showed that actually, if you give them probiotics, or actually even if you give them TMS, then you can stop that fermentation, and you can change the volatile acid production, and you can get rid of that sort of lesion. And they had a really nice fermented probiotic that contained all of these funky things. The closest version we've got in the UK is plus back manor herbs, maybe similar to what you're getting with some of the things available in the US, like Improvim, which is...
Well, that is quite interesting, because I guess you would want to be careful with what probiotic or what preparation you chose, because some of the prebiotics will contain those volatile fatty acids or be designed to try and increase those volatile fatty acids, because in your colon, they are a good thing. Is that fair?
I think it depends on, so if you look, you're coming out talking about how long does things stay in the stomach for. And I think because of the location of the fiber mat in the horse's stomach, it's very much a local fermentation effect. And because it's in contact with the squamous mucosa, it seems to be a local issue. I think if you're giving stuff that goes into the horse's stomach in any sort of fluid phase, it's going to leave so quickly that I wouldn't worry too much about that.
Okay, that's interesting.
This is another thing to think about. So don't get excited about these guys. So if you see these cool little lesions, they're called Barrett's change. It's glandular metaplasia in the squamous mucosa. In man, they occur at the gastroesophageal junction. They are non-painful. That is not an ulcer. That's where the squamous mucosa has had enough of acid exposure, buggered off, and been replaced by glandular mucosa. So remember, the margo plicatus means folded junction, and it's a junction that migrates like this in response to relative tissue growth state. In man, these are an obstruction to eating because of their location. In horses, they're not. But what it might let you know is that you've got a horse with a bit of a high or variable acid load producer. So if you see these, don't worry about treating them, but think a little bit about how acidic that horse's stomach might be. Is that good for squamous?
Yes, that is super, and I think everyone will. I think that is perfect for squamous. I think people will be very keen to hear probably more about the glandular lesions. I feel like everyone suffers from these horses where they see glandular lesions, they treat them and they think it's going to be great, and a month later things look terrible. Or even worse, there were no glandular lesions to start with.
Yeah, so I think when you start talking about glandular disease, we need to be a little bit better about describing it. And certainly we have, with Liverpool, we've kind of validated that endoscopically, if you biopsy these guys, what you're seeing endoscopically is actually correct. So I'm trying to encourage you to think about glandular lesions in two steps. And this first step would be the epithelial appearance. The first thing you want to get used to doing is what's called transillumination. So if you want to know if the surface of the epithelium is intact, get up quite close to it with your endoscope, play a little bit with how intense your light source is, and look for the crazy paving appearance. So if you look at this bottom sort of slide on the left, you can see little pink areas of tissue with little white surrounds. Glandular epithelium is a compound epithelium. It's made of repeating units. And you can see the little sort of delineations between those repeating units. When you transilluminate them, the white bits show up really nicely. If you can see that your epithelial surface is intact, you do not have a lesion. Even if the tissue underneath is hyperemic, you have an intact epithelial surface. We can talk a little bit about hyperemia, what it means later, remind me. Next picture over, you can see you've got erosion. So what you've got here is an obvious tissue defect, epithelial defect. When you get up and close with this, you will lose that crazy paving appearance. Because it's been denuded, so you're not going to be able to distinguish between those sort of tissue margins. Obvious ulcers, these are less frequent, but you do see them. And then we start to sort of deal a little bit with the coating. So you can get hemorrhagic inflammation over the top, and then you can get significant fibrinous-suppurative inflammation. Now, when you biopsy these guys, the ones with hemorrhage, you don't have as much interruption to your epithelial integrity. It's much, much milder. When you've got this inflammation, it's much, much more severe. And one thing that we do before we do any sort of gastric surgery is we hoover this stuff off. So you can use a PE tube like the sort you would do a BAL or a trach wash to, attach it to your suction, hover over these, and you can hoover off the mucosa, like this sort of mucousy gunk, and what you'll find underneath is they look like these eroded ones. So you've got quite big tissue defects. If you hoover these guys off, they don't look like very much at all. So epithelial appearance is number one. Mucosal appearance is number two. So you can have flat lesions, so no alteration in your mucosal contour. You can then have polypoid lesions, so these are the ones that are a bit more circular. So you've got a circular, sort of pretty well sort of demarcated thickening, and then you can have rugal thickenings. These are the ones that are much less sort of effectively demarcated. They're much more variable, and they're often much larger as well. And all this is important because it relates, and hope in a few slides' time, to actually how these guys heal. So, talking about glandular healing, there is no perfect treatment, despite what anybody would tell you. If you use any treatment enough, you'll find that you will get treatment failures. So none of them work perfectly. I think you need to be realistic about what you're hoping to achieve. So short term, for me, resolve the epithelial erosion and inflammation. Longer term, remodel the mucosa till it looks normal. You get the odd one, like this one above, that after a month looks absolutely brilliant. And I wish they all look like that. And I can't explain why some of them do and some of them don't. Just a bit weird, but you do get some that improve that quickly. But on the whole, these certainly for me are the time frames you want to be thinking about. Now, this is something that embarrassingly Chris Proudman and I did donkeys years ago and have never published, which is a bit shame really, because it's the only study that's looked at actually how ulcers heal differently by the location in the stomach. So we had 204 cases and we looked at different areas. So cardia, this area up here, contains somatostatin cells. It's essentially a pH sampling area. Fundus down the bottom is your big sort of acid energy area, antrum and pylorus. And what we found was if you've got lesions in the cardia and the fundus, they just go. They love to heal. If you've got antropyloric lesions, then your success is much less. So we had a consistent approach to treatment, and then we looked at the sort of differences in efficacy by area. So that's one thing that we found. And that's important when you start to look at any sort of experimental study, as well as in individual cases. So if you've got a predominance of cardio and fundic lesions, you're going to flatter your treatment. If you've got a predominance of antrum and pyloric lesions, you're going to impact your treatment. We then looked at the type of lesions. So with a combination of omeprazole and sucralfate, we found that flat or depressed lesions healed much more consistently. Hemorrhagic lesions healed more consistently than fibronegative ones. So our success rates were greater when we had less in the way of tissue remodeling, and were greater when we had less in the way of epithelial interruption, which kind of makes sense, really. And I think that's important because you can say that to clients. You can say, oh, you've got lots of, really lumpy snot-covered things. These are the ones that are more of a challenge. We absolutely need to sort of scope them again. So this is my approach. It is not the only one out there. It's the one that I kind of do. So step one for me, I tend to do oral or IM omeprazole and sucralfate. I do that for 28 days. I know some people like to do it for longer. Most of the clients that Sarah and I would deal with don't have the patience to last for 50, Sarah's chuckling over there, 56 days, so we do it for a month. I rescope them. If they are 75% better, I'm pretty chuffed with that. Keep going for a second month. If they are less than 75% better, I go to step two. If they look exactly the same, I tend to biopsy them. And we can talk about, I'd like to hear your thoughts on biopsy and anybody's thoughts on biopsy. Anyway, so my step two is meso. Once again, for 28 days, rescope exactly as above. 75% better, keep going. Less than 75% better, I go to another step. If they're no better, I biopsy them. My kind of step threes would be these guys. So if you find bacteria, which is infrequent, but they do happen, then what I would do is oral omeprazole to lower dose. So we want to allow a bit of acid into the stomach because we want to make it harder for bacteria to live. Sucralfate and doxy.
Vicky, can I just, are you saying bacteria on your biopsy?
So that's a good question. I think if you want to do it really thoroughly, and you look at some of the work that Louise Huster did, and we certainly, when we were biopsying them, you need to do three things, which is a bit tiresome. You need to remove some of the overlying goo, either by picking it off with your biopsy tool or by hoovering it up. You need to put that on a slide and roll that out and gram stain it. You then need to take a chunk of your tissue and you need to roll that out on a slide and gram stain it, and then you need to take another chunk and put it in for culture. So it's laborious. And we don't really know which of those layers is most important.
I guess, but if you're going to start giving horses with gastric ulcers antibiotics, then that's the stuff you need to be doing, right? You shouldn't just be.
I would agree with that. And I think the number that need it is really small. I think the ones that you see, it's brilliant. They do incredibly well. But I think the number that need it is really small. We then classify some of them as chronic gastric change. So these are horses that have got significant remodeling to their glandular mucosa. Hyperplasia, hypertrophy, all that sort of stuff. We talk a bit about those, I think, in a bit.
Yes, we should definitely talk about this. This is a cool topic. We'll come back to.
And then we do see some of the gastric IBDs. So I think if you've got a horse who has got other intestinal signs, so, intermittent colic, we know that gastric colic is rare, or they have intermittent diarrhea, you can't really explain that from a gastric point of view, then I would absolutely scan their abdomens. And if you see any sort of thickening, you may have a gastric manifestation of equine IBD. In which case, those guys, if you do biopsy them, you'll find that they're hooching full of lymphocytes. So it's usually a lymphocytic inflammatory response that they've got, and you put them on pred and they get better spectacularly well. So that's kind of my approach. How does that bear in? What would you do?
Well, since I work in your wide empire these days, this is also my approach. I have learned from the best. And I guess I like this approach, and I suppose I feel like quite a lot of people get in touch with us who've done quite a long period of time of misoprostol and sucralfate, maybe as their first line treatment, and it hasn't worked. And I suppose that has made me anecdotally feel like I would not reach for that as a first line treatment. I don't know how you feel about that.
Sorry,
Yeah.
Dicky, can I ask? Sorry. When you reach for misoprostol, do you stop the omeprazole and sucralfate completely?
Well, I think this kind of comes back to what Sarah had said. I would agree with you. Meso's not my favourite first line thing. Because I think if you look at the magnitude of acid suppression you get with meso, it's a lot less than you get with omeprazole. And I think, you know, clients will judge what you've done by how much happier their horse feels. And I think it can take quite a long time for glandular lesions to get to a point, and remind me, I need to show you a slide about that, get to a point where the horse is not uncomfortable when there's acid lesion contact. And so I think meso clinically is a disappointing drug, even if endoscopically it's a nice drug. To answer your question, Rach, yes, I will. I will give omeprazole at 1 or 2 mg per kg in addition to meso in a horse where clinical signs are a big component of that horse's presentation. Because I think, you know, often what you'll find is you switch them onto the meso, they get better endoscopically, but the client gets quite pissed off for about 2 weeks when the horse's symptoms come back. So I think that does kind of mitigate for that a bit.
Okay, thanks.
So antibiotics, we've talked a little bit about already. So when, rarely, and when they do it, amazing. This is a horse that just got better. I mean, I've been fanning around for about 2 months with omeprazole and sucralfate, stuck it on 14 days worth of doxycycline, and it just got better after we biopsied it. So I think, you know, biopsying has had a lot of bad press about it's pointless, why do we bother doing it? And I think on the whole, it is. You know, it hasn't revolutionized what we do. It hasn't given us an explanation for what causes these ulcers or put horses into particular treatment categories. But what it does do is help you to explain why your horse hasn't got better. And so I think using it selectively for those non-responders, I think for me, does make sense.
Yeah, and I guess it's worth saying we're not biopsying every horse. We're biopsying, as you said, when they're not improving.
Here's the IBD ones. So, you know, as I said, all that already. This is something I want to talk a little bit about very quickly, because if anybody's got any research money, it'd be a really cool thing to do. When you see these horses that have this snot pouring off their stomach like this, don't underestimate these lesions, because actually if you hoover that off, what you've actually got under there is really quite an angry tissue. And if you biopsy those, these are often really quite severe focal gastritises. The amount of tissue epithelial denudation they have is often quite small, but the amount of inflammation they have is really great. And what that can cause is it can stimulate quite a profound change in mucin gene expression. So the reason they look snotty like this is they're producing loads of loosely adherent mucus as a response to chronic irritation. These horses can be really, really annoyed. I saw one relatively recently that had a glandular mucosa full of these that was colicking periodically with it. So I think these are the ones that you sometimes underestimate.
I was just going to say we've got 15 minutes and 2 more big topics to cover. So, and this is the first one.
Right, chronic gastric change. This is a grandiose title for these sort of lumps that we see in horses' stomachs. It is something that we've been doing, I suppose, as a hospital for around about the last 15 odd years. When we see these guys in horses, we will scope them free of charge every 6 months for clients. So what we've got is a relatively quite an extensive data set of horses where we've tracked them clinically, tracked them endoscopically. These can be asymptomatic. So it's really important when you look at them. So compare the one on the left and one on the right. One on the right has got loads of these little polypoid change areas, but there's no inflammation. You can see the tissue, you can see the demarcation between your areas of thickened and hyperplastic tissue, but it's not inflamed. One on the left is full of hemorrhage and snot and nastiness. So the one on the left is more likely to be symptomatic. The one on the right is more likely to be asymptomatic. Ultimately, you may need to check and treat them just to see. Most of these do not impact gastric outflow. There are some that cause pyloric stenosis, absolutely, but most of these do not. Always have a peek, as this little video has just shown you, into the proximal small intestine. Have a look at that, see that it looks normal, and literally 999 out of 100 times it will. These are unlikely to become neoplastic. I can't say that they won't. I've seen a couple of cases of gastric adenoma in my life, and they do occur, but they're really rare. So when you have these guys, you have a couple of options. You can manage them. These horses will not heal. These lesions will not heal over a normal time frame, which means what you need to do is to focus on clinical signs. You want a horse that is clinically happy, whilst you've then got time to look at lesion improvement. And by time, I'm meaning months to years. So we put them on a step-down course of acid suppression, not because we're worried about any sort of hypergastremia, but we want to find the lowest effective clinical dose for these individuals. So when the horse is absolutely happy, and that can be 0, it can all be up to about half a tube. So it is very individual. At the same time, we tend to give them coating agents. So the theory behind these guys is you've got deformed tissue that does not produce a normal glandular barrier. You need to try and do something to beef up the barrier. So I tend to use apolectol, so pectin, lecithin, and the pronutrient we use the most commonly. 75 to 300 grams a day would be the dose. So what we tend to do with these guys, once they're symptom free, so once you've got control of their symptoms, stick them on the apolectol, do your stepwise reduction, and then after time, reduce your apolectol to once a day, rescope them after 3 months, and then after every 6 months after that. And if you've got a clinical horse who has got a stable endoscopic appearance, then that will usually work forever and a day. Sometimes things will change, they get concurrent disease, they move yards, something bad happens, all of that sort of stuff, and you'll lose control, but that's relatively unusual. So that's kind of option number 1, just manage them. And sometimes they will get better. I had one that got better over 9 years. Stomach now looks normal. Next thing you can do is just get rid of it. So in man, what you're looking at is polypoid change, hyperplasia, hypertrophy, deep fibrosis. And this is all the stuff you get when you biopsy these with a snare loop and you put them in for histopath. You can get rid of these. And you can either do them by a polypectomy snare loop with electrocautery or transendoscopic photoablation with a laser. So here is a snare loop example. This is a nice big old lump down on the sort of left-hand side of the antrum. Let me just jump that forward to where it gets a bit more exciting. So you need to do this in a stepwise fashion. So we inject these with a sclerotherapy needle with a combination of adrenaline and local anesthetic. If you don't, they will bleed a bit and the horse will get a bit pissed off with you. And I tend to go for about 1 ml of that combined solution, and it's a 1 to 10 solution per cubic centimeter of tissue. Then there's your snare loop, and you have to use a Storks one. They're the only ones which kind of work, and they're an elliptical snare loop. And you want to be not too greedy with how much you chop off, because these guys can be quite fibrous and you'll get quite a lot of charring. You don't want to cut and coag mix, you just want a cut mix. I use about 30 to 50 watts in around about 30-second pulses. If you pulse for much longer, sometimes the base plate will heat up and the horse will get more than averagely pissed off with you. And so the tissue goes nice and white, everything smokes a bit, and then you end up chopping stuff off. So you can see this one's chopped off. Before you do this, you want to suck out almost all the fluid in the stomach, otherwise you won't find your lump to remove. You need a helicoid or basket to then retrieve your lump. And then what you do is you go around sort of, snaring off your remaining chunks like that. You'll always end up with a little bit of thermal damage, and that thermal damage is good because what it does is it causes protein coagulation, and it will cause the sort of neighboring tissue to slough off like that. So that's kind of a bit of snare reaction. At the end of snaring them, we'll often laser them, and that's the sort of hemorrhage you'd expect with these, not very much. There's your thermal damage, that kind of whitey grey, tissue around the edge. If you've got a pedunculated polyp like this, 3 to 5 cuts is what I'd normally do, and they typically come away really well. In between cuts, you must remove your snare loop and you must clean it with a little wire brush to remove the charring, otherwise your subsequent cuts will not go well. That's polypectomy snaring. And this is a few more examples. So there you go, chopping one off. And this is what they ultimately look like. You ultimately end up with normal tissue because you've removed your polyp tissue. So it's a bit like removing proud flesh on a leg. Other option you've got is multi-stage laser photoablation. So we tend to do this for broad-based polyps. You just can't get the loop around it. So what you do with these guys, inject them with exactly the same solution. Then we hoover off all the inflammation. So there's no point in cooking the inflammation. You want to cook the tissue. And we either do a non-contact, so about 5 millimeters away to 10 millimeters away. You hover the laser over there and you cook it until it turns this rather unpleasant sort of purpley yellow. If you've got a big mass, you can see the far side of it. You can actually put the laser in, use a much lower wattage for a much longer period of time, and actually cook the tissue from the inside out. So you can do contact photoablation as well as non-contact photoablation. Post-treatment with these guys, when we started doing this, we thought, my God, hemorrhage and colic going to be really bad, because when Mike Murray and I were hacking chunks out of the stomach 20 odd years ago, they would bleed a lot. These guys don't. They just simply don't. So now we do this as an outpatient thing. We even do it at yards sometimes. If you likelihood of perforation, much less in man. Horse's stomach is much thicker. We're applying exactly the same sort of energy to a much sturdier structure. So touch wood, I've not seen that. Some of these can be a bit uncomfortable. So 24 hours of Phoenix and 48 hours of sucralfate if you're not already on that. I tend to put them on meso for me, because I think what you're doing is you're trying to enhance cellular restitution. Tend to rescope in about 21 days, and sometimes you'll need to ablate them further depending on how much tissue you've got out. As to how frequently you do it, how aggressively you do it, it is emerging. I think when we started doing this a few years ago, we were quite tentative. Now we're a bit more gung-ho with it, which means the number of treatments that we do has got fewer and fewer.
I love this. I'm naturally quite impatient, so it appeals very much to me. Okay, we have a short period of time left. I think it's all right, we might change tack a bit. I think it'd be quite good to talk briefly about gastric impaction and gastric emptying. Let's maybe start with, what is a gastric impaction? How do we know for sure if it's actually got an impaction, or did we just not withhold its food for long enough? Has it been eating its poo overnight? And I guess maybe we can talk a bit about the difference between those gastric impactions leading to some kind of colic where they resolve in 24, 36 hours versus those monster stomachs that have clearly been building for ages.
And I couldn't find my gastric impaction lecture notes, so I've just quickly thrown some together. But one of the things that Sarah talks about there is actually really important. So you will see gastric impactions that are a primary issue, the horse's only issue, and then you'll see some gastric impactions that occur alongside other intestinal disease, particularly large intestinal impactions. The ones which are primary gastric impactions, counterintuitively, often don't do as well as the ones that are in combo with something else. And I think that reflects the potential for impaired motility within the stomach, rather than just a general dysmotility or a shitty feed or that sort of thing. For me, when you're thinking about gastric impactions, you want to think about three things. Has the horse had access to crappy feed? So the purpose of the stomach is to soak sort of lignified forage. So have the horse had inappropriate access to crappy feed? That's question number one. Number two, does the horse have crappy teeth? So is it unable to grind its feed sufficiently that the stomach doesn't have to excessively soak it? And then number three, do we have an issue with the horse's gastric function? And that issue can either be squamous paresis, the sort we see in, familiarly in Frisians, or I think more commonly squamous stretching that we see in horses with chronic infections, or it can be a sort of pyloric issue and an outflow obstruction. When we look at motility, so fluid phase half-life about 30 minutes, solid phase half-life about sort of 4.5, 5 hours. When we talk about solid phase, we're talking about 3 centimetre sort of hay. If you're looking at stuff like grains, then it's around about 2 hours. So it's kind of in between the two. And when you look at stomachs, they do have this layering system. So it's not just a giant bowl of porridge. What you've got is your pellets down here, your grains in the middle, your chaff up there, and your hay up there. And so whenever you see an impaction and you manage them, you can actually exploit this. So if you're changing the way that you're feeding them, if you give them a pelleted diet, that's going to come down to your fluid phase. It's going to empty really quickly. So you're going to be able to provide quite a lot and often sufficient nutrients by doing a completely pelleted diet. Anyway, I digress. Look at the position of where the hay sits. So the hay sits up here within your dorsal squamous fundus. It's designed to sit there. It's a progressive soaking effect. It doesn't want to move out. It wants to hang out. So if you have a gastric impaction, it's going to be there. So when you first come in with your scope, you're going to see this. You're going to hit food balls straight away. If you can get around it and it's down the bottom, it's probably delayed gastric emptying. Or sorry, not delayed something, so inappropriate eating. The horse has just found something. When you look at impactions, picture on the left, this is a smooth, hard food ball. Poke it with the scope, poke it with your biopsy tool, squirt some water at it. It won't change. It's really dried out. When these guys belch, you'll smell it. Have a look at the picture on the right. This is a layer of, so a layered, look like an onion. So what you'll find is you get this silvery appearance on the outside. That's dehydrated salivary mucins, and you'll get layers of this silvery appearance that when you squirt it hydraulically, it starts to fracture in layers. They don't form overnight. A little bit there, another bit, another bit, another bit. So you'll see it. The first thing I would say is look at its position, try and break it down. When you do break it down, look at how it breaks up. If it is an impaction, it'll look like that. If it's a uniform thing, the horse has just eaten its poo or it's found something to eat. I've got closed circuit TV videos of one horse being fed by a neighbour. And so, you know, things happen with these guys. And sometimes they can be quite small. So this one up at the top here is teeny weeny. So it's not very big. But you can see it's got that same sort of silvery appearance, and it's taken me quite a lot of effort with my pressurized water sprayer to break it down. Next thing to look at is look at what the squamous mucosa looks at behind it. So you'll either get this sort of sloughing where it's just been stuck to it, the whole thing's dehydrated. Remember, this is the same lining as the esophagus. This is like a long choke. So what you're going to end up with is mucosal changes. And, you know, it can be peeling of that, or it can be the sort of ulceration you can see here as well. So look for those. If you've just got inappropriate eating, the mucosa will look normal, or you'll just have classic ulceration.
Cool. Should we talk briefly about treating those proper gastric ulcers? Shall I? Well, maybe I'll go on a brief Coca-Cola rant, or is this going to be controversial? I don't know. I feel like maybe it's going to ruin people's evenings. I guess here we would predominantly go for maceration and rehydration, and they clear very well well, that's not true. They don't always. If they're massive and enormous, it's going to be difficult. But the Coca-Cola thing, I'm afraid, it's just a myth. So it's really acidic. The pH of Coca-Cola is like 2. The stomach is already acidic. And some of these horses, people are giving omeprazole. Why pour acid in there? And then what else are you doing? Some bubbles. I think we fire water out of the scope at these things. And then you're like, oh, good, a little tiny piece of hay came off. Some bubbles are not going to have any particular effect. So anyway, I'm sorry. I feel like possibly this is an excessive rant. If it makes everyone happy to put some Coke down there, do. But don't think that it's going to have dramatic effects. Also, you should definitely use the sugar-free one and the caffeine-free one, at which point it's really just really acidic carbonated water. So
I agree completely. I think it's a horrific waste of Coca-Cola, really. For me, what I tend to do is just what Sarah does. So I tend to hydraulically break them up with the scope. So we pump it through the scope at relatively high pressure, and usually I normally put about 6 to 9 litres in there. Try and turn what you've got into a bowl of porridge. You know, what you can then do is you can suck the air out and then keep pumping in. So you can put a relatively big volume in there. Next thing you want to do is use your scope to measure the start and the end of the impaction, and then put those measurements onto your stomach tube. Because then you know that your stomach tube is sitting where the impaction is, and it hasn't just gone all the way over it underneath your lesser curvature and down to your antrum. And then what we tend to do is a large volume lavage. So I mean, we'd put 60 or 70 litres in and out, usually with a stirrup pump to try and further break it down.
10 litres at a time.
Yeah, exactly. No, exactly. Yeah, that's a good point. So we normally have sort of 2 buckets, sort of 10-litre buckets, and so you know exactly how much is going in and out, in and out, in and out. And that can clear them really quickly and easily. And if they're, you know, if you've got a bit that's a bit hard, then just put your stomach tube back in at that starting point and put another liquid in it overnight. I think warm water works just as well.
And I do feel like that approach is different probably to how I used to do them historically, and I think it works better. Faffing on just trying to put fluid in the stomach for long periods of time is quite unrewarding, I would say. Super. I think we are getting short on time, and I realized at the beginning I forgot to encourage people to put their questions in the chat. But do people have questions, cases you want to talk about? If you do, either raise your hands or type away in the chat box, and we'll see what we can do. Well, actually, I say we'll see what we can do. Dicky will know the answer. Or is everyone just exhausted?
Oh, go on. I'll ask a random question. We have an ongoing debate at our practice about removing air post-gastroscopy, which I never bother with. I've never had one colic, but it's a debate, and I just wondered if you bother.
I do, but then that's only because I've got a suction pump with me. I like you. I don't think it makes any difference whatsoever. And I've got a horse who's being a knob. Then I'll just pull the scope out. I've had one which has colicked, It wasn't actually me scoping it. It was a fellow colleague at a beaver course donkeys years ago, and that had been scoped, you know, when we're teaching people to do it, for about an hour and 10 minutes. You know, it had multiple doses of DOMO and a lot of air, and it did have that segmental jejunal volvulus that is reported in the literature. It didn't go to surgery, luckily. It had lots of sort of pain relief and farting and that sort of stuff. I think that paper that talks about complications of gastroscopy, I reviewed that, and I think it's bloody awful, because what they selectively did was to look for complications over a time frame, and then only look at the scopes, you know, other scopes within that time frame. And I think that's simply wrong. They should have looked at the whole time that they were scoping. So they vastly overestimated the frequency of complications.
And
so
there is the one very alarming 2 cases of small intestinal volvulus after gastroscopy. Those 2 cases, I don't know how many tens of thousands of horses have been scoped.
I don't overinsufflate when I'm in the duodenum. I don't usually look at the duodenum unless I'm worried about duodenal disease. You know, if you've got something like a high bile acids, we had a nice one of an Optocefalum magna the other day, you know, stuck at the end of its bile ducts, causing a sort of an extra hepatic obstruction. But unless there's something I'm thinking about finding in there, I don't bother going in the duodenum. And if I am in the duodenum, I don't insufflate too much. I think you can over-insufflate the duodenum, but I think that's very different to putting air in the stomach.
I don't put the pump on in the duodenum, but is that being too weedy?
No, I think if you can see it, who cares?
Cool, more questions. Rich Frost says, if tapering the omeprazole dose, are we just acid suppressing for longer?
Yeah, so what you're doing predominantly with tapering doses is you're essentially looking at the horse's lowest effective dose. And what you're mainly doing is reducing the duration of acid suppression. And so you don't need to acid suppress for 24 hours to heal a stomach. You probably need to acid suppress for about 15 to 18 hours. Realistically, most ulcers form in the daytime. If you look at selective feed starvation, then if you starve from 7 a.m. to 7 p.m., you'll get ulcers. If you starve from 7 p.m. to 7 a.m., you won't get ulcers. So I think if you are dose reducing, what you're doing is reducing the amount of time that the horse's stomach is acid suppressed. Therefore, you're reducing the potential for ulcer recurrence. And I think the amount of time that is required is individual for horses. And I think that reflects a bell-shaped curve of acid production. I also think it really reflects the effort that the individual owner puts into making sure that they're doing the lifestyle change junk. I'm a big proponent of corn oil. I think it's probably for me the most useful intervention that we do. And I know that David Marlin has a lot of issues with it, and I think he's missing the point really. So I think I'm going to put this one slide up because I think it's important, because the guy who did it is Al Merritt, who's a hero of mine when it comes to gastric gland. So Al Merritt had ponies that were cannulated. So you sucked all the juice out their stomach and you looked at acid load. So that's the amount of acid they make over unit time. And what he showed was if you give them corn oil or rapeseed oil, 40 mils twice a day for 6 weeks, then you reduce by about 1/3 basal and pentagastrin stimulated gastric acid secretion. And so it has a profound physiological effect on gastric acid production. Also, you know, improves PGE2 and bicarb output and all that junk. It will not stop a feed deprivation model. Nothing stops a feed deprivation model other than omeprazole. And when we did the consensus statement, we said we shouldn't be doing the feed deprivation model because it doesn't fit with how horses live. It's artificial. It served a purpose to look at how Gastrogard worked, but we don't need to do it anymore. So, being mean about David Marlin, his using of that particular study to say it doesn't work is missing the point of how it works. If you give them lots of it for a week, it's not how it works. It's a small amount for 6 weeks. So for me, that's my main recommendation. I think it's one everyone should do.